CPAP versus oral appliance therapy at the age of COVID-19. Just a picture of our facility and our teaching center. We have a lot of fun there. Hopefully we'll be able to have people there again in the near future. By way of disclosure, I have no vested interest in any appliance, device, or technology. I maintain a sleep disorders dentistry practice, conduct research, and provide educational programs. Our facility is accredited by the American Academy of Dental Sleep Medicine, and the facility and all our programs follow AASM and AADSM guidelines. So there's two learning objectives in this short presentation. Basic review of sleep disorder breathing and therapies for those of you that have not heard much about it before, and then overlay on top of that the impact of COVID-19 on the sleep disorder breathing treatment options. So sleep disorder breathing refers to abnormal breathing during sleep. At one time, we could say that it was ignored by primary caregivers, family physicians, but that's no longer the case. They've become very well versed with the importance of making referrals to sleep specialists. However, we can still say that oral appliance therapy option is still often ignored by primary care physicians simply because of a lack of awareness. They have ignorance in this area. Of course, this disorder is associated with major health consequences, which we'll review over the next few slides. And it's important to realize that the dental office is ideally positioned to screen, refer, manage, and monitor these patients. So sleep disordered breathing, abnormal breathing during sleep, leading to insufficient ventilation, reducing the amount of oxygen you're taking into your body. You can see in this little picture where the red circle is the tongue has collapsed and blocked the airway. So the airway blocks in multiple different areas. It could be at the soft palate, behind the tongue, lower down at the epiglottis and the hypopharynx, all the way down to the glottis. We have stoppage of breathing for 10 seconds or more with arousals and blood oxygen desaturation. This would be an apnea. Or we can have hypopneas or RERAs, where we get arousals from a deeper stage of sleep because of shallow breathing and blood oxygen desaturation, or arousals without blood oxygen desaturation. Net result, of course, is disruption of the sleep cycle. So you are fatigued during the day, but also deprivation of time spent in deep sleep, stage 3 sleep, and REM sleep. Now, this interferes with very important physiological processes. What are the solutions? CPAP on the face, continuous positive airway pressure, blowing air up the nose, down the airway, and helping to maintain the airway open and patent while you're breathing with and against this flow of air, or oral appliance therapy. These are the two most common and highest success rate conservative therapies that are available. Oral appliances work by muscular activity helping to maintain the airway. And in some very difficult cases, sometimes combining both an oral appliance and positive airway pressure results in the best outcome. Okay. So let's seek some perspective here. What is this all about? Okay, so you stop breathing, your sleep is disturbed, you're tired, but what else happens? Well, lots else happens. Hypertension, atherosclerosis, myocardial infarction, chronic headache, risk of errors increased, decreased focus, daytime vigilance is a problem, loss of energy, loss of interest, feelings of worthlessness, depression, type 2 diabetes, glaucoma, and decrease in hearing for both the snorer and the spouse, and decrease in libido. When we talk about longevity, what happens? Well, it'll shorten your lifespan. This was an 18-year follow-up. After an initial sleep study was done, patients were followed for 18 years, and here's what they're looking for every year is, are they still alive? And here's a chart 18 years later. For the patients that had no sleep apnea to begin with, well, about 94% of them were still alive. For those that had mild sleep apnea, about 89% of them were still alive. Patients that had moderate sleep apnea, about 84% of them were still alive. For the patients that had severe sleep apnea, about 58% of them were still alive 18 years later. So there's no question, there's plenty of evidence in the literature that there's a high mortality risk associated with untreated sleep disordered breathing. This is independent of age, sex, and BMI. Unmanaged OSA shortens your life and reduces of your quality of life. Okay, so if you wonder what's the big deal aside from the snoring and you wake up a bit tired, there's a lot more to it. Now, seeking a little bit further perspective, worldwide, approximately 1 billion people have sleep disordered breathing, and approximately 85% of them remain undiagnosed. If we look at US statistics, 20 million have asthma, 23.6 million have diabetes, and 42 million adults have sleep disordered breathing. Over 80% of these 42 million remain undiagnosed. ResMed, the inventor of CPAP, did a market study just to better understand the climate out there. What they uncovered is that 30% of patients that get referred for a sleep study don't bother going. 82% of these patients would be positive, and half of them give the reason, I don't want to use CPAP. Most often it's because they think CPAP is the only thing they're going to be offered, and they don't even realize that there are other alternatives available for them. In 2016, the American Academy of Sleep Medicine commissioned a report by Frost and Sullivan. Approximately 6 million diagnosed with sleep apnea in the US. 60% remain compliant with treatment. 40% non-compliant. And the reason they cited discomfort and inconvenience of CPAP. Not offering these patients a viable alternative results in a similar consequence as if they had never been diagnosed in the first place. At least we're helping 60%, right? Well, this is a study of just shy of 3,000 patients, all at cardiovascular risk. All were given the appropriate counseling regarding lifestyle, diet, exercise, and so forth. And half of them were given CPAP. After a 7-year follow-up, there was no significant difference in prevention of cardiovascular events compared to CPAP versus the controls. Now, there was a little bit of head scratching that went on here because there's other evidence in the literature that shows that you do get cardiovascular protection from wearing CPAP. However, when they looked more closely, what they discovered that this compliance was 3.3 hours per night. So people were on the average for this group wearing their CPAP 3.3 hours a night. So clearly, wearing your CPAP only 3 hours and a bit every night is not going to give you the cardiovascular protection you're hoping for. This comprehensive systematic review of 82 papers found the rate of CPAP adherence remains persistently low over 20 years worth of reported data. This low rate of adherence is problematic and calls into question the concept of CPAP as gold standard therapy for OSA. Okay? So there's plenty of evidence in the literature regarding the poor compliance, yet gold standard for sleep disordered breathing is the moniker that continues for sleep apnea. I think there's overwhelming evidence that the emperor has no clothes, said the young boy that grew up to become a dentist. In fact, really, CPAP is gold standard for approximately 1/3 of patients, because that's all that can wear their CPAP and comply with wearing their CPAP all night long. The next third wear part of the night, then take them off, so they're suboptimally managed, and then the final third can't deal with it at all or refuse to wear it, so they're not managed at all. So this gold standard moniker is very deceiving because it does not take into consideration how well patients can tolerate using CPAP and how often they do. So why is CPAP adherence acceptable to physicians? That's a head scratcher. We look in the literature, 29 to 83% are non-adherent, defined as a mean of less than 4 hours of use per night. Now, the mean use was 3 hours per night amongst the non-adherent patients. So we know those people are not getting the cardiovascular risk they're hoping for. However, when we look at hypertension, only 50% of patients will take their hypertension meds as prescribed. Asthma, 12% use their asthma meds as prescribed. As a matter of fact, when we look right across the board at prescriptions, only 25 to 30% of patients take their prescriptions as prescribed. So physicians, medicine, they're accustomed to patients non-adhering with something that's prescribed. The reason CPAP is considered gold standard therapy is they know if the patient wears it, it'll work 100%. That's pretty good. There's very few things in medicine that can be prescribed that have that high a success rate. So they're very proud of that discovery of CPAP. Problem is that the compliance defeats that completely and reduces the overall therapy to a group of people down to a much lower number. And the gold standard moniker is very deceiving. So we look at CPAP therapy, pumps air into the nose, through airway into the nose, through the nose into the airway, and then splints your airway open so it doesn't collapse. We know that there's about 2/3 compliance after 6 months. This study happened to be from back in 2000, average of 3 to 4 nights per week and 3 to 4 hours per night. This study published an adjusted effectiveness, taking into consideration both compliance and effectiveness, and they put the number at 50% for CPAP. Okay. Now, oral appliances hold the jaw forward, maintaining the airway through muscle activity. Compliance, approximately 90% after 2.5 years in this study. Other studies range between 85 and 95%. I think 90% is a pretty realistic number to quote. Health outcomes are similar to positive airway pressure, likely due to superior compliance. This was what was concluded in a 2013 paper. Adjusted oral appliance effectiveness was published by Van der Weken at 51% in 2013. So let's look at CPAP versus oral appliance therapy. This first conceptualized comparison shows the results on a sleep study, polysomnographic efficacy, the ability to reduce that number of events down to below 0. Well, CPAP is red, blue is an oral appliance. CPAP wins every day of the week. However, when it comes to symptom control, similar. When it comes to health status, similar. Health benefits, I should say. When it comes to adherence, oral appliances win out. Tolerance, oral appliances are superior. Patient and partner acceptance, oral appliances are superior. And convenience, oral appliances are superior. When it comes to affordability, the net cost is about the same for both therapies. However, this end cost to the patient is going to vary depending on the region and the country. Insurance reimbursements are different in different regions, and in some places they have socialized medicine that covers it, in other places they don't. Okay. Now, if we take a look here at a crossover style study, outcomes measured after 1 month, oral appliances versus CPAP, 24-hour blood pressure, oral appliances and CPAP are the same. Driving simulator performance, same. Daytime sleepiness, same. Health-related quality of life, oral appliances are superior in some domains. Once again, when it comes to AHI, apnea-hypopnea index, the ability to reduce the number of events down below 5, oral appliances are inferior to CPAP. Self-reported compliance, oral appliances are superior, and patient preferences, oral appliances are superior. Okay. So this was published by Van der Weken in 2013, discussing the concept of mean disease alleviation, taking into consideration both how effective the therapy is, along with the compliance rate associated with that therapy. As you can see with CPAP, the mean disease deviation is 50%. And its Achilles heel is adherence. So how do they improve adherence? By trying a different mask, by reducing pressure, and by trying AutoPAP, a different machine where the pressure ramps up and down as per patient's needs. So oral appliances, the mean disease deviation is 51%. The Achilles heel for oral appliances, very high compliance at 91%, but it doesn't always get rid of the apnea. The residual apnea is still there, and in this particular study, about 44% of cases. So what do you do for those individuals? Well, you can try and advance in them further. And with appliance wear, the ability to advance further increases with time. So they initially get their appliance, they may be maxed out at a certain position. Well, 3, 4, 5 months later, maybe they could go that much more forward and be able to get into a more efficacious position now that their body is letting them accommodate to that advancement. So that's something that can be tried. We can change the vertical. There's a subset of patients that will benefit from a more vertical. Positional therapy, counseling the patient on how to stay off their back. There's weight loss that can be used adjunctively along with wearing the appliance and wearing the appliance. Combination therapy, combining both the appliance with CPAP. Lifestyle changes regards to when you eat your meals, how much you eat late at night, changes in smoking, alcohol intake, and so forth. Surgery, sometimes ENT can go in and remove some redundant tissue, which will help the cause. And something very new to North America from the UK, tongue muscle toning, basically neuromuscular stimulation of the tongue to improve its fitness level and help it help to maintain airway patency during sleep. That can be used adjunctively along with an appliance. An appliance then is either the journey, and for 56% of patients it could be the full journey, or it is the start of the journey to wellness, where we look to these other adjunctive therapies and use them alongside the appliance to take you the rest of the way. So let's look at market trends. This chart runs from 2013 to 2020, and you can see that by and large, patients are mostly prescribed CPAP. In 2020, I should say, 80% prescribed CPAP, 40% won't use it. So what happens to the 32% of CPAP prescriptions that don't comply? Well, we know they're not getting appliances because in the same chart, it shows that appliances are 10 to 12% of the time. Unfortunately, they often remain unmanaged. They fall through the cracks and don't end up doing anything. And the dental practice can do wonders to help capture these patients, get them back into treatment. We need to increase awareness for oral appliance therapy, and we need to start with our very own patients and then reach out to the community. A little bit of an overview of the current guidelines. These are 2015 guidelines jointly published by the American Academy of Dental Sleep Medicine, American Academy of Sleep Medicine. Let's start off with the sleep physician is a sleep specialist, sees the patient and conducts a sleep study, reviews it, and then makes behavioral recommendations. It could be something as simple as staying off your back is all the patient needs. If there's snoring and that needs to be remedied, well, then an oral appliance is considered first-line therapy. If, however, there is any severity of sleep apnea, mild, moderate, or severe, CPAP is considered first-line therapy. But if the patient can't tolerate CPAP, or if the patient simply prefers an oral appliance to CPAP, an oral appliance is considered a standard of care for any severity of sleep apnea, mild, moderate, or severe. Okay. The important thing to know is that for mild sleep apnea, the likelihood, the odds of the appliance taking the apnea down into the normal range is equal to CPAP. When you're talking about moderate to severe sleep apnea, then the odds of an appliance eradicating all of the apnea goes down. It's not as high as CPAP, but it works at all levels of apnea. It just may not get rid of everything. For one patient with 100 events per hour, it could take him all the way down into the normal range. And for another patient, it might only bring it down to 50. So this particular patient approached me about an appliance, and the sleep physician flat out refused to write him a prescription, said it won't work, you're too severe. He had 72 events per hour in his back. Overall average was 23 events per hour. Well, he was entitled to a prescription. The sleep specialist was wrong in taking that position, and the patient got a prescription from his family physician. We made an appliance, and the net result was 2.4 events per hour overall and 2.8 events per hour on his back. So we eradicated his apnea completely when the sleep specialist would not even consider writing a prescription for him. Think about it. If this patient had been prescribed CPAP and left with that option only, he voiced his non-adherence clearly, he would likely have died younger than he needed to. By providing options, you will have better outcomes. There's no question about it. I'll take it a step further. If you do not provide options, or if you discourage other options, you're actually doing harm. Telling a patient appliances don't work or will not likely work may be steering them away from the only effective conservative therapy alternative available to them. Physicians and dentists need to cooperate and work collaboratively in this environment. And that we're a long ways from that. I've seen improvement over the last 25 years, but unfortunately, there still remains a tremendous amount of ignorance on the physician side. They just don't get exposed to the information to understand the role oral appliances can play. And so if one of your patients is in this situation, in the dental office, it's up to us to become their advocate and make sure the patient gets the help they need. So in a COVID-19 world, how does it change things up? The question you may be asking is, well, isn't PAP first-line care? Why does it change? Well, the answer to that is no, not in this environment. So let's review things. COVID-19 pandemic has highlighted medical implications of PAP aerosol. Okay, something we never thought about before. PAP implicated with the spreading COVID-19 within the Washington State nursing home that became ground zero originally in North America. We essentially aerosolized it, said one responder. We made it worse. Redmond Fire has now discontinued the use of PAP for COVID-19 patients. That PAP masks leak is well established in the literature, and it's a known fact. ResMed, the inventor of CPAP, makes it clear that it's not a good versus bad dichotomy. It's a range. A little bit of leak is okay as long as it's not interfering with the efficacy of CPAP. However, when we're dealing with a contagious virus and potentially spreading it, is a little bit of leak okay? And we really don't know the answer to that, so people are trying to err on the side of caution. The American Society of Anesthesiologists recently advised against PAP use for COVID-19 patients based on the experience with the 2003 SARS epidemic, and also studies that suggest PAP pumps virus into the air, potentially spreading disease. Dr. Camila Sasson, an associate clinical professor of emergency medicine at the University of Colorado School of Medicine, recommends not to use it because we are concerned about community spread. Toronto firefighters, right here at home, firefighters that wear CPAP themselves are no longer allowed to have night shifts and sleep at the fire station with their colleagues wearing their PAP. They've been given day shifts until this pandemic is over. And the concern is, of course, especially in light of the fact that some positive carriers are symptomless, that they will spread the virus around to other firefighters and end up with a problem within their station. American Academy of Sleep Medicine, a medical organization that oversees sleep, if you will, currently recommends that if a PAP user becomes COVID positive, they should speak to their physician about assessing risks and benefits. The persons at risk are basically everybody else that is sleeping in the same home. Patients should not stop using their PAP without first consulting their physician, and they should actually move to a separate room or a part of the house that's far away from everyone else where they're using their PAP. They should speak with their physician, and which together they can weigh the pros and cons. Depends on if there's people in the home that are susceptible and that are high risk, and exactly the level of apnea that we're dealing with. All of the pros and cons, risk to the patient, risk to others around, have to be taken into consideration before making a decision. Now, there's been much discussion about the new normal post-COVID-19. A new level of vigilance will be exercised in the use of PPE in our offices. Regarding oral appliance therapy, it will be interesting to see if the well-entrenched bias for use of PAP over the oral appliances will manage OSA will persist. It'll be interesting to see if there's a change in sentiment. Current events may greatly influence the manner in which physicians, dentists, teams, and patients view the oral appliance alternative to managing OSA. Remember that even the very best fitting PAP device leaks. Okay, this is the limitation of the technology, and this has been acknowledged by ResMed, the inventor of PAP. We know it's the case, it's not speculation. The question is how meaningful it is. Now that we know about this liability associated with PAP, we can never unknow it. COVID-19 is not the first contagious virus, nor will it be the last. So what are the benefits of oral appliance therapy versus PAP? Well, oral appliances reduce the likelihood of contaminating surroundings with virus-laden aerosol. Ease of disinfection of oral appliances versus PAP. Oral appliance, you drop into a glass of water with a little tablet or powder. That's it. With PAP, you have to disinfect the machine, the hose, the mask, and you have to use distilled water. You have to use special cleansing solutions. There might be shortages of these. You know, it's cumbersome to do. It's definitely not something people are going to do on a daily basis. So there's those two main differences. Published just in the last 10 days during this pandemic, it is reasonable to assume that patients would prefer a therapy that both treats their OSA and does not increase the risk of COVID-19 transmission. This is published by the American Academy of Dental Sleep Medicine and the Journal of Dental Sleep Medicine just about 10 days ago. Here it is. And what they say is oral appliance therapy is an effective treatment for OSA without increased risk for transmitting COVID-19. Patients who prefer oral appliance therapy may be more likely to adhere to treatment if they are confident that their therapy is not putting those in their household at increased risk of COVID-19 exposure. Now, in a perfect world, physicians and dentists would be working collaboratively together, making discussions together. So it's interesting, the AASM, which is the medical side, has taken the position that if you wear PAP and you have COVID-19, you should speak to your sleep specialist as to precautions to take and what to do. AADSM has taken the position, heck, if you're in a COVID-19 environment, when we don't even know who has COVID or not, because of symptomless carriers, everyone's better off just getting an oral appliance, at least for the time being. So we have two opinions by the two main academies that use the evidence-based information from the literature to come up with guidance. And it'll be interesting to see what the American Academy of Sleep Medicine puts out to reply to this position the AADSM is taking. They are now no longer under the same roof, but two separate organizations, two separate households, if you will. So this is going to be interesting to see how it unfolds. Key points: with patient preference, oral appliance therapy is a standard of care for all OSA severity. PAP creates aerosol and is cumbersome to disinfect. Oral appliance therapy does not create aerosol and is easy to disinfect. AADSM recommends oral appliance therapy as first-line therapy during the COVID pandemic. Given a choice, which would you prefer to use personally in a COVID environment? So the take-home message here, we need to ensure that patients understand their options fully. Okay? Patients that come into your practices and have been talked to about their sleep apnea and CPAP, it's unlikely they've been talked to about oral appliance option and the role it could be playing. So if those of you that are hygienists play a major role in communicating with your patients, and of course any other dental auxiliary and the dentists themselves, in helping to be patient advocates, if you will, to help the patient get the care they need. Because all too often, if the patient drops off PAP or refuses to use PAP, they end up doing nothing at all. So visit our online resource center and online learning platform called stdacademy.com. You'll find archived episodes of Dental Sleep Medicine in 5, lots of very provocative, interesting topics. We have our Pi Corona webinar series all archived there. We have our Dental Sleep Medicine chat room sessions archived there, talking about different timely topics. We have free online programs, introductory programs appropriate for patients, for the team, for the dentists, for physicians, human resources officers. We have free ebooks. The CAD-CAM ebook is for clinicians managing patients with the various CAD-CAM appliances, nylon and polymethyl methacrylate appliances. And then there's the Airway Aware ebook that is appropriate for anyone that is responsible for other people, whether a human resources officer, a teacher, a coach, a parent, any team leaders. Basically, if you're responsible for other people and you need to keep them healthy and you need to keep them working optimally, this is an ebook you should read. It's not a long read, but there's very important information as to why the airway is important, how it impacts on performance and overall well-being, and how you can have your team working optimally by making sure that they've screened themselves. And then there's little posters you can put up on the ceiling over the hygiene chairs that are free downloads. So thank you for spending this time with us. If you have any questions, please feel free to email me at john@drviviano.com. Visit our online academy, stdacademy.com, and look forward to see you sometime in the future. Thank you and sweet dreams.
Thank you, Dr. Viviano. This was amazing.